Hello, everybody. Thank you for coming. There's a couple quick announcements before our presentation today. As always, make sure to follow us on LinkedIn and list this as one of your experiences. Also, make sure to like and subscribe. We're going to be sending out the quiz afterwards, and make sure to take your time and answer. Hello, everybody. Questions. Thank you for coming. There's a couple. Make sure to answer those questions to full of your abilities so you can get the most out of the experience. Everything Shellcast related is in our link tree in our bio. It's on our Instagram at ShellcastMed, so make sure to follow us there. And now time to introduce our presenting physician, Dr. Watchmaker, Dr. Jacqueline Watchmaker. She is a dermatologist, currently completing her fellowship in cosmetic surgery and laser treatment. She completed her residency in dermatology at Boston Medical Center after graduating from the Medical College of Wisconsin. We're super excited to have her here. If the last name looks familiar, we had her sister on here as well. And we know that when a watchmaker's on, it's going to be a great presentation. So without further ado, you can take it away.
Hi guys, thank you so much for having me. I'm honored to be giving this presentation. I love dermatology and I'm excited to share with you a little bit more about the field. So just a little bit about our short presentation today. I'm going to give you a brief introduction to what dermatology is. I'm going to take you through a typical day with a few cases of things we typically see on a day-to-day basis. I'm going to show you some of the fun tools that we get to use every day. And then I'll talk a little bit about my path of dermatology, as well as kind of tips that you can take home with you if you are potentially interested in a career in dermatology or any medical specialty. And then I'm hoping I can convince at least one person to consider a career in dermatology. So just a little bit about me. I love dermatology. I love the skin. I think it's super interesting. Dermatology is a very diverse field, and I'll go a little bit into that more in the next few slides. I am a board certified dermatologist. I went to Medical College of Wisconsin for medical school. I'm from Wisconsin. I did residency at Boston Medical Center, and now I'm doing a laser and procedural dermatology fellowship in Boston as well. I'll be practicing general, procedural, and cosmetic dermatology in Phoenix, Arizona, starting next November. And I have a twin sister that I know we briefly talked about before, but she was also a presenter on Shellcast previously. She is an interventional radiology resident. So what is a dermatologist? Very basically, it's a doctor who specializes in not only the skin, but also conditions of the hair and nails. In dermatology training, we learn about over 3,000 different skin, hair, and nail conditions that board-certified dermatologists can adequately diagnose and treat. And we care for people of all ages, from newborns to seniors, which is another part of the field that I love. So just a little glimpse into a few of the conditions we treat, and some of these are common and some of these are more rare. So this is just acne, very common. See this multiple times a day. This is something a little bit more rare called lupus, discoid lupus specifically. This is something called keratosis pilaris. It's common on the back of the arm. Some of you might have it, but we commonly see that. This is melanoma, so this is the most rare, but also kind of the most scary type of skin cancer there is. And we're extensively trained in how to diagnose and treat skin cancers. This is something called psoriasis, which is also quite common. And this is something called contact dermatitis, basically an allergy to something that comes into contact with the skin. And you can see this probably was a little tattoo in the shape of a dragonfly that the patient was allergic to. So this is just a very quick glimpse into, the 3,000 things that we see and diagnose. So the language of dermatology. I remember my first time shadowing a dermatology clinic, I was a little intimidated because the language and the words and the descriptive terms that we use in dermatology are unique to the field. And in medical school and in pre-med training, we don't get much exposure to these words. So just for example, sometimes we describe things as like papular, peritic, polygonal, papules, and plaques, which can kind of sound like a tongue twister. We say things like conified scaly plaques with fissuring and superficial erosions. And this kind of language of dermatology just helps us communicate to other physicians and, accurately document and track patients' conditions. Some of the diagnoses, as well as some of the descriptive terms, can kind of sound a little foreign, and I feel like some of them sound like they should be in a Harry Potter book. Things like lichen sclerosis erythroficans, hidradenitis suppurativa, and erythematolangiotatic rosacea. So I just wanted to introduce these kind of descriptive terms and some of these intimidating words to tell you not to be intimidated. And at first it can be scary. But you learn as you go along, and it ends up being kind of a fun, different language almost that you get to speak as a dermatologist. So a few things about why I love being a dermatologist. It is such a diverse field. I know it seems like it's just the skin, how much can there be to it? But I love treating, we treat newborns up to, very, very old patients. And I love seeing that kind of range and ages of patients. It keeps things exciting and different. We get to treat very healthy patients, with just, a minor rash to very, very sick patients in the ICU with full body rashes that, have very serious infections or skin conditions, reactions to medications. We treat conditions that are quick and easy to cure, which can be, fun and fulfilling for both, myself and the patient. But we also, partner with patients and treat conditions that are more complex and chronic. So we do, get to see many of our patients and follow up. So a lot of skin conditions, we have medications and treatments to make them better, but not necessarily cure them. So we, really get to know some of our patients long term. And I love that dermatology is kind of a mixture of medicine and surgery. I know going through med school, I really liked every rotation I was on. If I was on OB-GYN, I thought I wanted to, do OB-GYN. If I was on internal medicine, I thought I wanted to do internal medicine. And I, got to the end of my rotations and I was a little bit confused. And then I shadowed dermatology and I loved it because there's, bits of oncology, bits of medicine, bits of surgery, bit of pediatrics, geriatrics, rheumatology, it's kind of all mixed into the field of dermatology, which I love. I love that it's an interdisciplinary specialty. So what does that mean? Sorry, that's a page. What does that mean? We work with a lot of different specialties. So especially rheumatology, a lot of, conditions cross over between dermatology and rheumatology. We work with oncology, so the cancer doctors to treat, advanced skin cancers that might have spread to other parts of the body. We work with allergy and immunology. We work with infectious disease doctors. So I love kind of partnering with other physicians and other specialties, to treat patients with more complex conditions. I love that patients are your partners. I think dermatology, everyone says, is such a visual specialty, and I love that. And I think, patients see their rash, see their skin condition, see their skin cancer, and then can also see when it, is getting better. And I think people are really invested in their skin because it's something they can see and they can see the improvement. Yeah, I love that it's fast paced. We see, 30 to 40 patients typically in a clinic day. So we're always kind of on our toes, running around. So that's something I love, but also something if you like, not such a fast-paced environment, maybe dermatology isn't for you, but keeps things exciting. So a day in the life of a dermatologist. Usually arrive between 7:30 and 8:30 to clinic, and this is a typical dermatology clinic room. And I'll point out a few things. So on the wall you'll see a hyfricator, which is a device that we use sometimes to stop bleeding, and sometimes we use it to remove some superficial benign skin growths. Bright lights. Dermatologists love light and bright lights. It's important so we can see every nook and cranny of the skin and, accurately, see, even potentially small skin cancers. You can see over here a few biopsy supplies, and we'll go into that a little bit more too. And a Mayo stand here to, help put tools on when we do procedures. And then there are some gloves over here, and then a sharp spin over here as well to dispose of needles and scalpels and such things like that. So our first patient of the day is a 56-year-old male with a history of extensive sun exposure, and he's concerned about this new bump on his leg that has been growing. And I might describe this as, a 6 millimeter shiny pink papule on the lower leg is how I would, describe that. So you're concerned that it could be a skin cancer because it's new, it's growing, it's in a patient with a history of extensive sun exposure. So what we would do is set up for a small biopsy. Biopsies in the clinic take, less than 5 minutes. We do them often, very quick. Patients heal great. And it can help us identify both skin cancers and other skin conditions. So some of the tools we use would be injectable lidocaine, which is right here, an alcohol pad to cleanse the skin. This is something called a derma blade, and I have a picture of that, which is something we use sometimes to take a small biopsy. A little bit of aluminum chloride, which helps stop the small amount of bleeding that occurs after a biopsy. And here's a little bottle of formalin to preserve the biopsy in. And then Aquaphor or Vaseline is what we use on top of the biopsy just to help it heal quicker. So we're going to go through the steps of a shave biopsy. So first you numb the skin with some lidocaine, and then use a derma blade, which is that special tool that we often use just to shave off a little bit of the skin to send to the lab. And then we send it to the lab in this formalin container. And here is kind of more pictures of what it looks like to do a shave biopsy. You just take off, the small concerning bump. And this will heal in nicely. So you get the results back from the lab, and it shows this. And something that I, as a med student didn't fully appreciate is, as a dermatologist, we're trained in clinical dermatology, so seeing patients in the clinic, but we're also trained in dermatopathology, which is, the study of skin conditions under the microscope. And about a third of our boards are actually kind of slides like this, and we have to identify, skin conditions. So there's like peripheral palisading and these like blue cells is classic for a basal cell cancer, which is the most common kind of skin cancer there is. And so we diagnosed this patient with a nodular basal cell cancer. And the treatment of choice is just a simple excision because these cancers don't tend to spread, deeper into the body. They stay on the skin. We excise, the skin and about 4 millimeters around the margin of the original skin cancer, and it's cured. So for when the patient arrives for excision, you just numb the skin similar to what you did for the biopsy, but you draw a little bit, bigger of a margin to make sure you get it all. And then you cut out just the top layer of the skin to make sure you get all of the skin cancer out. And then you would send this to the lab to make sure it was, completely clear and the margins didn't have any skin cancer on them. And then you sew up the incision with some stitches, and then you would see the patient back in about 2 weeks to get the stitches removed. So I kind of like, as a dermatologist, you can, diagnose the skin cancer clinically, confirm your suspicion with the pathology, and then, actually excise the skin cancer completely. So, so that's one patient. And then the second patient of the day is this patient, an 8-year-old child, comes with his mom. He's had, rashy skin his whole life, but the condition has recently worsened, and the patient is complaining that the rash is scaly and itchy. I might say this, there are lichenified scaly plaques in the antecubital fossa, is how I would describe this skin finding. And atopic dermatitis, some people also refer to it as eczema, commonly presents in childhood. And this presentation, similar to what was on the previous slide, is classic. In the antecubital fossa, it can be scaly, it can be red, it can be pruritic, which means itchy. So you diagnose this patient with atopic dermatitis. And you prescribe topical steroids, which are very, commonly used in dermatology to calm down skin inflammation, help with itching. And then you counsel the patient on how to use the medication, as well as other gentle skincare practices, such as using, a good thick ointment moisturizer twice daily. Sometimes we use something called bleach baths to help remove some of the bacteria on the skin and also help decrease the itching. And the patient comes back a month later after using the topical steroid and doing some gentle skincare, and the patient is much improved. And the redness, scaling, and pruritus, which is itching, have resolved. And you make a follow-up appointment to see the patient sometimes in the fall with the drier weather. Atopic dermatitis or eczema can get worse. Some of you might have experienced personally. So usually we like to see these patients, at least, once or twice a year, just to follow and make sure their eczema is under control. That's an example of a pediatric patient. And then our third patient of the morning is this patient, and she is a 42-year-old female. She presents to clinic with red cheeks that flush when she eats spicy foods. She's very embarrassed by the redness and is hoping you as a dermatologist can help her. And she also notes some small red papules, which is the medical term for bumps on her central face. You can see those kind of right here that are sometimes tender or painful. So this patient has classic, what we call rosacea, and we use lots of different treatments for rosacea, sometimes topical creams, sometimes oral antibiotics, and that can really help, especially with the red bumps. And then as far as kind of the background redness, that's when lasers can play a role in treatment, and it can help the laser can collapse down some of those red vessels. And decrease the background redness as well as the flushing. One laser that we commonly use is a laser called the pulse dye laser, which targets blood vessels and collapses them. And here's just a little video of the laser. And you can see just a little cold spray to protect the surface of the skin. And then you might have seen a quick flash of yellow. The green light is there just, I don't know if you saw that quick flash of yellow light. That yellow light is very well absorbed by blood vessels, and it causes those blood vessels to collapse. So oftentimes we use this laser on the cheeks, but it can be used for anything red anywhere on the body to kind of help treat it, be it, acne, scars, rosacea, anything like that. So after the topical cream as well as the laser treatment, you see the patient back and she's very happy with the results, and you can see the bumps have gone and the background redness has also improved with the laser treatment. So 4:30 p.m. is around when clinic is over, and at the end of the day, sometimes you get biopsy results back and you call the patients and make some treatment plans. Often, dermatologists take inpatient calls. So if there's a patient in the hospital that requires a dermatologist, you can go see those inpatients after clinic. And then I just want to talk a little bit about some of the fun tools that we use as dermatologists. So microscopes, we use microscopes a lot. I know we've already talked about the dermatopathology aspect of dermatology, but we use microscopes for many things in the clinic every day. Sometimes we can identify scabies under the microscope, which is what this shows. And sometimes, fungal and yeast infections, we can also diagnose very quickly, in 5 seconds under the microscope. And here's a typical microscope. I'm sure all of you know what one looks like. We use liquid nitrogen a lot, which is something we call it cryotherapy, cryo meaning cold. And we use liquid nitrogen to freeze warts, but also freeze kind of benign skin growths that are either irritated or inflamed or itchy. And here's just a short video.
Ready? 1, 2, 3.
And then the growth on the skin after treatment with liquid nitrogen might get a little irritated, and then it will just fall off with time. Some of you might have had, warts frozen when you were little, and we use cryotherapy for that often.
Ready? 1, 2, 3.
And then lasers. I love lasers. I'm kind of doing an extra year of training in laser medicine. We use lasers for so many different things, both cosmetic things, but also medical things as well, such as rosacea, like we talked about. We use it for port wine stains, which you might have heard about. We use it for bad, acne scarring or, burn scars, laser resurfacing. We use it for, pigmentary changes that patients would like to improve, tattoos, all sorts of things. So here's just a few examples of some laser procedures. So that is a resurfacing laser. It's basically kind of taking off the top layer of the skin. And then this is a video of using laser to help remove some sunspots on the skin. We also often use something called a Woods lamp, and it helps pick up pigmentary changes in the skin. So if you might have heard of melasma, which is kind of darkening, dark spots on the face, or we also use it for vitiligo, which is white spots on the face or body. And certain bacteria can also fluoresce with this Woods lamp. So you can kind of see the pigmentary changes here before treatment, and then after it's much more uniform. And then here is just, I'm looking at the back to make sure there aren't any subtle pigment changes on the back. And then one of my favorite tools we use every day is something called a dermatoscope. It uses polarized light, so we can actually see like a millimeter or two underneath the surface of the skin, and it can help us see structures of both benign but also malignant skin lesions in closer detail. And there are certain patterns that would be concerning for a skin cancer, and certain patterns that are more, typical of a benign lesion. So we use it along with just, our eyes to kind of help tell us one way or another if something should be biopsied. And this is what a dermatoscope looks like. This is a concerning lesion for melanoma that is under a dermatoscope, and this is kind of how we use it in clinic. So how do you become a dermatologist? 4 years of college, that I'm sure all of you know, 4 years of medical school, 1 year of internal medicine, or you can do pediatric training, which is often referred to as an intern year. I did training in internal medicine for a year. And then it's 3 years of dermatology training. So the residency in total, including the intern year, would be 4 years long. And then you can do an optional fellowship. In dermatology, all the fellowships are just 1 year long. It can be in lasers. It can be in Mohs surgery, which is a specialized form of skin cancer surgery that's often performed on the face that helps conserve tissue, but ensures that you get the entire skin cancer out. And then most surgeons do like reconstruction to make sure the patient is left with, a cosmetically optimized scar. There's also dermatopathology fellowships. There are pediatric dermatology fellowships. So there's lots of options for fellowship if you do go into dermatology. So in college, taking the pre-med courses is obviously essential. Getting involved in research projects will look great for medical school applications. Seeking out mentors, early on in college who can write, good, strong letters of recommendation is important. Seeking out pre-med advisors as well as, older college students who are on the similar pre-med path is, good to get advice from. I think holding leadership positions and volunteer positions is important because I just remember I got asked a lot about this on my medical school interviews. And I think I took the MCAT around junior year. I think that's about when people still take it. And I just wanted to point out, I was a dance major in college. You don't have to be a science major in order to be pre-med or go into medical school. I think in college you should do what you want. Obviously, you have to take the pre-med courses, but you definitely don't need to be a science major in order to be a doctor. And then in medical school, keep an open mind. I had no idea what I, wanted to be when I was starting off medical school. Explore a lot of different specialties. If you can, shadow a few times in a few different specialties during your preclinical years, just to start giving yourself an idea of what you might be interested in. If you do think dermatology is for you, getting involved, in research projects and, seeking dermatology mentors is helpful. And taking an elective during your clinical years kind of earlier on, if you are interested in dermatology, I think is also helpful. You can attend, conferences. We have conferences all over the country multiple times a year. They're super fun. They're great to network. They're great for learning. So I would recommend those. And then find older students who, are also interested in dermatology and ask their advice. Because I think things, the applications change, year by year, and getting the most up-to-date advice, I think, is important. And joining a dermatology interest group if your medical school has one. So just to wrap up, I know we briefly talked about this, but a career in dermatology, what could that look like? You could be an academic dermatologist working at a big academic medical center. Oftentimes, very complex patients are referred to academic centers because we have a lot of different subspecialties that can really work together nicely when we're all, located in a large academic hospital. You can be a private practice dermatologist. You can be a Mohs surgeon who specializes in that skin cancer surgery, a dermatopathologist who primarily, identifies skin conditions under the microscope, pediatric dermatologist. You can do inpatient dermatology where, your primary patients are, sick, hospitalized patients who have skin conditions. You can do lasers and cosmetics, which I'll be doing, for part of my career. So that's the end. And I'm so happy to answer any questions anyone has. Feel free to email me with any and all of your questions. And I recently started a dermatology focused Instagram where I post little videos and things that I do every day. So if you want to follow me, it's Jacqueline Watchmaker MD on Instagram. And I don't know if there's any questions or.
Yep, we have a couple, and I highly recommend you follow our Instagram. Great tips for skincare and very satisfying videos like those laser videos you showed. Always great. We do have a question. You mentioned how multifaceted you guys are in terms of what you treat, especially with oncology, with the skin cancer and rheumatology and even pathology. How much does your treatment and training overlap? How much do you, do you ever bring in oncologists, or are you trained to, handle all three of those things on your own, or do you ever, outsource them to other specialties?
That's a great question. So in residency training, we often have multidisciplinary clinics. So we called it room derm clinic, where the dermatologist and the rheumatologist would, go in to see the patient together and kind of together jointly, discuss the treatment plan. And obviously the dermatologist would have, more recommendations for skin specific treatments than the rheumatologist, maybe if the patient also had internal issues that were concerning. And then oncology, we also had a multidisciplinary cutaneous oncology clinic where, again, we worked, hand in hand with the, oncology team for patients with advanced skin cancer. So I think, for many things, dermatologists in training, we learn from the rheumatologist, we learn from the oncologist, we learn from the pathologist, and many of the things we can kind of, treat on our own, but we often do, ask for help and refer, patients to see rheumatologists if you're in private practice, and then kind of, work together to provide the best care to the patient. So yeah, so I'd say some of it we treat ourselves and we get good training on, but some of it we ask for help, whatever's going to be best for the patient.
Yeah, I love seeing intermingling between specialties and communication. On the same multifaceted topic here, you said you see a wide variety of people from young to old, healthy to sick, even just cosmetic patients as well. How do you alter your approach or alter your style to deal with different types of patients, since you deal with so many all the time?
That's a good question. I think I just walk into every room, with an open mind, and sometimes we have like stickers and toys to help, when we're treating the kids, and sometimes we have to jump from a small child with a birthmark to like telling an older patient that they were diagnosed with a melanoma. So you really have to kind of like flip back and forth, and you really have to like be dynamic and multifaceted, and like I said, it's like fast paced, but I think it in training and just in practice, you like learn how to kind of like jump back and forth between all those different patients, and just make every patient feel like they're your only patient of the day.
Right. Do you have like a basic recipe you follow to help with like treatment, or like you said, is it just very dynamic and multifaceted? Do you have like the same thing you do for the patient history, objective findings, differential diagnosis, things like that?
Yeah, it's very tailored to the patient, and also like the severity of the condition. So like for instance, like the eczema patient that I presented on, there's depending on how itchy the patient is, we might add in an oral medication to help with itch. If there's some bacteria on the skin that I think is complicating the eczema, you would add in a topical or oral you know um, antibiotic. Most patients with eczema need a topical steroid, but there's all different, strengths and levels, and there's creams, there's ointments, there's all different, different formulations of medication. So there are similarities and things that we commonly prescribe for certain common conditions, but every patient is different, and I don't think I tell. It's rare, that in the same week I tell the patient the exact same kind of, diagnosis or the exact same kind of treatment regimen. Um, so yeah.
Yeah, definitely keeps it exciting.
Yeah, keeps me on my toes.
And one thing I always really loved about dermatology, and everybody goes through phases where they have an obsession with like skincare products and their morning night routines.
Mm-hmm.
It's such a ever evolving field with like two new technologies, like you shown with the lasers, and new products. How do you stay up to date on current research, current advancements, and best practices, and when you're so busy dealing with so many patients all the time?
Yeah, that's a good question. And I think, as a dermatologist and as, a consumer too, you have to really look at every, advertisement and every trend with a very, critical eye. And, we have, really great medical journals that like highlight, high quality peer reviewed, research on, different ingredients in skincare products and, different, trends in dermatology. And, I think we, especially as dermatologists, need to, practice evidence-based medicine and not, recommend things or skincare products to patients just because it's, the trend on Instagram. So that's also something I try and do or I've been trying to do since I've started my Instagram, is like, not every trend is worth following. But also, I think another great thing is, we haven't been able to do it this year because of COVID, but going to our big dermatology meetings, we talk about, the latest trends and, what we should be recommending and what shouldn't we be recommending. And, the data gets presented by some of the smartest people in our field. So I think, reading the journals, looking at everything with like a critical eye, and then attending conferences is kind of how I stay up to date on, trends and things like that.
Um, and also on that, is a field of dermatology like making those products? Is that like a subspecialty of like pharmaceutical dermatology? Is that a subspecialty, or is it just a group of chemists that kind of work with dermatologists to make those
Yeah. It depends on the product and the brand. A lot of the brands do partner, very closely with dermatologists to create products, that are safe and effective. But it's always, a partnership with industry. Sometimes there are dermatologists who, primarily focus on like industry and, making products and devices, but usually it's like a partnership with a clinical dermatologist and a company.
Right, right. And in terms of research during your residency or even during your fellowship, how big of a role did that play? And did it interest you at all? Is it something you look for, or something that you in the future want to get into?
Yeah, I love research. I think in undergrad and even med school, at the beginning of med school, research kind of intimidated me. But research doesn't have to be this like big scary monster, just like even, describing like a case series or an interesting case report, or, a new treatment option for a rare condition, that, is research. And I did do a lot of research in medical school residency, and I have in fellowship. But I think once you get into especially residency, it's kind of most residency programs have like a minimum requirement, which is, 1 or 2 research projects throughout your 3 years of dermatology, which is very, manageable and achievable. But if you want to do more, I think it's fun. I like contributing to the field and, getting new ideas out there and presenting at national conferences. Like I enjoy that. So but I think if you don't like research also, it doesn't mean that dermatology isn't for you.
And also in terms of your residency, one common theme that we get a lot is how grueling residency can be for a lot of specialties. And please excuse me if I'm wrong, but it seems like dermatology has very solid hours in terms of 7:30, 4:30 in and out. Is residency a lot more intense than that, or is it about the same schedule and hours?
Yeah, I think dermatology has a good work-life balance. I do think dermatology residency, compared to some other residencies, there's a lot of like after hours reading and studying, because there are so many dermatology diagnoses and a lot of them are very common, but a lot of them are rare. And as a board certified dermatologist, you have to identify those like super rare conditions that you might have only read about in a book. So I will say, in residency, my hours are pretty much, 7:30 or 8 to like 4:30 or 5. And, you do take call. I got a page during my presentation that I'll have to answer after this. So, you do get called after, and sometimes you have to go into the hospital after hours. But overall, it's a really good, work-life balance. And I wouldn't say it's too grueling, but I did spend, you can ask my husband, many, many, many weekends in residency, with my head in the books, just like studying. Even though I technically wasn't, at work, I was doing work.
Now that you've gone through, residency and fellowship, and you're about to start practicing on your own, what are some misconceptions that pre-meds or even med students have about dermatology? And you know, what do you think is like the cause of that misconception?
Yeah, I can kind of think of two. One, that dermatology is super easy. And I remember someone once telling me like dermatology, if it's like wet, dry it, if it's dry, wet it. like as like that's like all there is to dermatology. And I think it's such a like broad, diverse field. And I think sometimes people outside of the field don't fully appreciate kind of how broad, the things we treat are. So I would say that's one. And then the second is I know there's, um, a talk about, competitive specialties and, thinking, like you might not be able to like match into, a more competitive specialty like dermatology. But if you study hard and work hard and, find good mentors who will support you, like anything, if you can get into medical school, you can like 100% be a dermatologist, and you shouldn't be like scared off by, thinking of it as like a competitive or difficult specialty to get into, because everyone can do it. I mean, it just takes, some work, but everyone is smart enough.
And I know I touched on this a little earlier in terms of, working with other specialties and subspecialties. Do you have any other healthcare professionals in your office? Like, do you have like a PA you work with, or an MP you work with?
Not myself. There are some dermatology I know, especially in private practice and academics, who, incorporate PAs and NPs into the office flow. And but I don't currently. But I love NPs. I love PAs. I think they do have a place in dermatology. So yeah, but I currently don't work with one.
And one thing that you mentioned earlier that really interested me is that unique, like possibly very rare, because you said a lot of things are common, but a lot of things are very rare. Um, how do you make those differentiations, and especially when you're, seeing 20, 30 people a day, like you mentioned, how do you, keep yourself sharp and like try to figure out exactly what's wrong with them, in terms of, is it just, eczema, or is it just something worse? How do you, keep that always in the back of your head, and how do you, try to dwindle it down a little bit?
Yeah, so I think it can be hard, especially if you're seeing a lot of patients every day. But keeping up to date on reading, I'm reading medical journals, but reading like our big textbooks. There's great online resources. Like one of them is Visual DX, where I think something, is this rare diagnosis. I can type it into Visual DX, and then it pops up all these pictures of even rare diagnoses, and I can kind of like say yes or no if I think that might be it. Trying common treatment options for common things first. Sometimes we'll cure things, but then having an index of suspicion. That if it doesn't respond to the common treatment options, like for eczema, that maybe you will need to biopsy it in the future. And there are certain things that can kind of like mimic eczema, like something called like mycosis fungoides that is rare, and it's kind of a biopsy. You need a biopsy to really diagnose it, as well as like some blood work. So I think, just staying up to date on reading, and if things aren't getting better with, treatments that you think they should get better with, then, biopsying and pursuing, further tests down the line.
Right. So do you have any type of protocol when the patient leaves, or is it just, their treatment with you, okay, I'll see you next week? Or is there some type of protocol you go with as soon as you're done with the patient? In order to, it could be something as simple as, writing them prescriptions, or like you said, checking out the pathology of their labs or anything like that. Do you have like a certain thing you do, or is it again just, still dynamic, just changing?
Yeah, it's dynamic, it changes, but sending in prescriptions, following up on lab reports, following up on biopsies. I often, for some of the very common diagnoses, I have these like sheets that, I have that, we give to patients that, have specific instructions on what to do, and also like warning signs or things that they should, come back sooner than their scheduled appointment, or call the office, if certain things are happening that shouldn't, be happening. So I wouldn't say I have like one specific, protocol that I usually use, but yeah.
Right. And one thing I love, and one thing that I really like about medicine, is how open it is new technologies and like new advancements and everything like that. Everything seems so, futuristic, Iron Man-ish.
Mhm.
I'm just looking at it. Is there any advancements in the field that, are coming into play or just starting to coming into play, that are, really, interesting or really like, you know, up and coming in terms of their effectiveness?
Yeah, that's a good question. There are always kind of like new medications coming into the field of dermatology, especially like for psoriasis and atopic dermatitis and even vitiligo. There's new medications, like some brand new medications, but also medications that are kind of like have been used historically for other indications that are now being like repurposed and studied for other skin conditions that have like shown some promise. So that's always exciting. And then there's always like new lasers, new devices, new like tools that are coming to the market for um, like there's like this new one that is supposed to kind of help treat like benign skin conditions, unlike kind of some of our previous tools, and it's supposed to maybe be a little bit better. So there's always kind of like new emerging devices as well as medications that are coming to the field, and some of them end up working out great, and some of them we end up forgetting about because they don't work so well. But it is a really quickly and ever evolving field, which is always fun.
Right. Switching gears a little bit to your more motivations in medicine. When you were in undergrad or even high school, or towards the end of your undergrad career, how did you decide that medicine was for you, and how did you put that to the test? Because I know a lot of our viewers are in undergrad right now, and med school it's a big decision to make. It's a big commitment. So what did that look like for you when you realized, okay, this is for me? And what helped you get to that decision?
Yeah, I think I always was drawn to the sciences. Like biology was like my favorite class in high school. I loved my biology classes in undergrad. Um, so I think that kind of helped steer me at least towards kind of like the medicine science path. And then in undergrad, and even before that, I did like shadow, and I shadowed all different types of doctors, and I have some family members who are doctors, and I just kind of you know, everyone seemed happy, and I think I love interacting with people, and I think being a doctor, you interact with people every day, and I like that component of it. So I think between liking science, liking shadowing, having mentors who are happy in the field of medicine, all kind of pushed me down, not pushed, gently encouraged me down this path, and I'm very happy that I tell my husband every day that like I'm so happy to be a dermatologist and be a doctor, and I do think it's my calling. I love what I do. I love my job, and I don't think everyone can say that. So yeah.
It seems like you had like a whole bunch of great mentors that helped you out along the way. How would you recommend younger people seek out these mentors? How do you recommend you seek out them? How you choose the right ones, uh, or and still continue that relationship?
Yeah, I think in undergrad it can be a little hard, if there's a professor you like who taught a course that you did really well in, and you liked the material, just I think setting up a meeting, with anyone is a great idea, so they can get to know you, you can get to know them, you can ask their advice on things, and I think that's a really great initial step, to like find a mentor. And if you connect during that meeting, ask for advice and research advice. And I think working on research projects with mentors can really show them that you're one, truly interested in the subject matter. It can really showcase your motivation, it can showcase your intelligence. So I think getting involved in research, you know big or small, is a great way to foster a relationship with a mentor, and just staying in touch. I think especially in academics, like you're never bothering someone by just simply reaching out and asking questions or asking for, a short meeting. So I think, don't be scared to ask for help and reach out and, continue relationships and, you call them, email them, I think everyone, in a mentorship role just, wants to see their mentees succeed in, any way possible. So.
And we have a question from the audience. Sarah's asked, what was the best piece of advice or a piece of advice that stuck with you throughout your journey? It could be from anybody, your mentors, family, anybody. And she wants to thank you for coming on and said your presentation was very interesting.
Oh, thanks, Sarah. I think the best piece of advice I ever got was like, don't compare yourself to others. I think it's super easy in undergrad, especially if you're like pre-med, comparing yourself to other pre-meds and, worrying that you maybe like didn't get the score someone else did, or you didn't get honors in a class that someone else did, or, someone got 10 med school interviews and you got 2. Like, don't compare yourself to anyone, do you. That's enough, work your hardest, be your best self. And I think once I kind of internalized that, my stress level like significantly decreased. And I think I was like more successful because I was just like more confident in myself when I wasn't comparing, my success to other people's success.
Right. That's definitely something, that's plaguing even pre-med and even med. And another thing that's a big plague is, burnout and, overexerting yourself because you're always expected to go above and beyond in everything you do. So what are some ways that, you dealt with that stress and you decompressed and, prevented burnout? Because it's a long journey and you don't want to burn out too early.
Yeah, it is a long journey. I think focusing and devoting your energy to things that you're really actually interested in and not just like think you should be interested in, to look good on a piece of paper, can really, help burnout. Because if you, kind of like the work you're doing and find it interesting, it's going to be, less stressful and you might look forward to, working on a paper if you're really interested in the topic. I think, and for me, I know at the beginning of med school, I didn't really take this advice, but like having some work-life balance, like you can't work all the time. Like you need to take time for yourself. Like you'll be a better med student, you'll be a better pre-med, you'll be a better doctor if you, take time to sleep, take time to see your family, take time to exercise, even if it's, occasionally. So I think like really devoting time to yourself and, to your friends and family and to things that you find interesting all at least have helped, prevent me from burnout.
Right. And, we kind of asked this question to a lot of our presenting physicians. If, your pre-med self or your med school self or anybody you would really want to guide was standing in front of you right now and you're just sitting down having a coffee or whatever, a matcha if you like that.
I like matcha.
Yeah, you're having a matcha and you've gone through everything. What was the one, piece of advice you would give her, one piece of guidance, or if any at all, you would, want to tell her?
I would say work hard, study hard, but don't kill yourself and have a little bit of fun. Like it's a journey, like it's a marathon. It's not a race. Like any sort of, pre-med path, like it's long. Everyone's going to make it. Most people are going to make it, but you got to give yourself time to relax and be happy. So I would probably tell myself that. So I forgot that a little bit at the beginning of this whole journey, but now I've re-remembered. And yeah.
Yeah, I'm very happy you mentioned that because I know myself, I forget a lot, and people watching forget a lot. Well, I think that's all the questions we have for you today. We want to thank you so much for coming, and so much for letting us into your life. We really appreciate it. And to all our viewers, we're going to drop the quiz down below in the chat. Make sure you really take your time out on really think about those journal questions because you did go over a lot today, and we want you guys to get the best out of the experience. Make sure again to join our email listserv add us on LinkedIn. Make sure to follow us and Dr. Watchmaker on Instagram. We're going to have her Instagram in the chat, and we'll also have it on our page. Make sure to follow her. And again, thank you for watching, and thank you, Dr. Watchmaker, for coming out.
Thank you guys so much.